Hello and welcome to the American Society for Stereotactic and Functional Neurosurgery webinar series. We're very happy to have you here and also hope that you join us at the end of this month for our biennial meeting, which will take place May 30th through June 2nd in Cleveland. So today we'll continue in the second part of our webinar series surrounding topics around the surgical management of refractory epilepsy. And I'm delighted to introduce our moderator, Bornali Kundu, who's an assistant professor of neurosurgery at the University of Missouri and also a rising star in our field. So thank you, Bornali, for moderating this session.
Thanks, Dr. Benheim. That's very kind. So yes, today we'll be talking about how to select optimal implantation sites and approach seizure networks when planning stereotactic surgery, stereo EEG procedures. So we have a very experienced multidisciplinary group, of course. And so our first speaker will be Dr. Sandipan Pati. He is a professor of neurology and directs the Division of Epilepsy at the University of Minnesota. He did his residency at the Barrow Neurological Institute in Phoenix, as well as some training in the UK. He did his fellowship at the former Massachusetts General Hospital, now Mass Gen Brigham. And he will be starting us off by talking about intracranial target selection for planning surgery and some aspects of interpretation as well. So thanks, Dr. Pati.
Thank you. Thanks, everybody. Let me see. I'm sharing my slides. I have 15 minutes, right?
That's correct.
I am a fast talker.
And we will have time for questions at the end, 10 minutes. So if you have questions, please put them in the chat, and I will try to keep track of those, and we'll have the speakers address them at the end.
Okay, so I think I'm going to start up with basically, essentially, target selection, a little bit summary of stereo EEG, a little bit of the history, and then go directly into how we interpret the SEG. So the SEG, the history actually goes way back into 1950, 1960, when Bangpo and Talarak, they actually developed this system. And this is very unique, a bit different from the way we have looked, North American have looked into subdural. And the other important point is that, the way the system, the electrode implant, even in 1960 when they developed, it was not just orthogonal, but they did had some oblique, as you can see in the picture, oblique electrodes, because there's some debate about, how much these oblique electrodes should be continued or not. So that's why. So the overall methodology of the SEG is it's not just depth electrode, it's more than there is a science and art to it. And the way the SEG is interpreted is more of an anatomo-electroclinical methods, which I'll describe a little bit. But more important before that is to understand the epileptogenic zone, which is, the concept is a bit different from how we at least from my training when it was more of a grade-based training, North American training. So it's a bit different. And I think those conceptual different, is important to understand. So what's that epileptogenic zone? So it's in a hypothetical area. It's sort of after resection or ablation, if the patient is seizure free, then we say that was the epileptogenic zone. So it's an area of cortex that is indispensable for the generation of epileptic seizure. In other words, the part of the brain that's absolutely necessary to generate and sustain seizures. This is slightly different from what we do as seizure, what we define as seizure onset zone. And I'll show you some pictures what it means. But then, when we do the SEG, we need to have some sort of operational definition. And I think the key point here is that it's not only the site where the seizure starts or initiates, but it's that primary organization of the epileptic seizure. It's that second part, the primary organization of epileptic seizure is different from the way we looked at subdural electrodes and the seizure onset zone, where we used to say where exactly the seizure started, the ground zero, the time zero, But in epileptogenic zone operational definition, we look not only the onset of the seizure, but how the early spread of the seizure, how it evolves, and the semiology emerges from there. So that's the difference between the olden way of looking and then the epileptogenic zone operational definition. So this is a conceptual picture that combines Banco, Talarak, and then Patrick Chauvel. And if you look in this picture, what it's telling is that one can have an epileptogenic lesion, and then you have the irritative zone, which could be primary and secondary irritative zone. And then the epileptogenic zone in this situation is actually the part of the brain where not only the seizure started, but also the primary irritative zone. And it includes not just the onset, but the early organization, evolution of the seizure. So that's how it combines the epileptogenic zone. So the key concept here is that two things. One, every time we are reading the SEG, we are also first looking into interictal discharges and then looking into the seizure. Sometimes you'll see that we find a place where we see the seizure onset zone. We see in the SEG that the seizure started and we see some changes, but we do not see a lot of interictal discharge. You should immediately question that. That is this the true epileptogenic zone or not? Because by definition, they must have it's not an option. They must have interictal discharges, and then we see the seizure onset zone. Then the next concept comes is that how do we distinguish primary and the secondary irritative zone? This is an evolving thing, and there are different ways people are looking into it. So first was the high frequency activity, including the oscillations, that then evolved into nowadays people talking about gamma spike or spike and waves and oscillations, HFOs with spike and waves climbing on the HFOs. And then there are new ways of looking into it, including certain time frequency decomposition, including what they called as epileptogenic index, or the other way is called fingerprinting. So there's different ways that things evolve. But that's one of the way of identifying the primary irritative zone from secondary irritative zone. And when this is combined with the way the EEG is interpreted as anatomo-electroclinical hypothesis, where one looks into the spatio-temporal organization of the epileptogenic zone, in other words, looking at not just the onset, but how it evolves, how it recruits different parts of the brain, and how the semiology then evolves. So it's a sort of the distribution of how the seizure is evolving over time is taken into account. So the old way when we were taught about seizure onset zone, SOZ, that O is now replaced by not seizure onset zone, but sort of the organization of the seizure. That's what is the best way to say the seizure organization, which from the French perspective is what they call as the epileptogenic zone or epileptogenic network. So these are some of the ways, as I said, that it's one of the evolving knowledge, how we distinguish epileptogenic zone from seizure onset zone. One could be just by looking at the EEG onset patterns. And among the many patterns, one of the striking sort of the patterns that has been consistent and people found associated with good outcome are low voltage fast activity. The second is just by analysis of multiple spontaneous seizures. The sort of stereotypic appearance is what alludes to it. The third is stimulation-induced seizure. This is a bit different from the subdural era where in the SEG, we are actually stimulating to actually replicate the seizure. Then the next one is the interictal discharge, where we are trying to distinguish between the primary irritative zone from the secondary irritative zone. And this could be done through what I just described before, looking into HFOs or different type of time frequency methods. And then the last two are sort of very new, different connectivity methods that have been proposed. But essentially, these efforts are towards identifying or delineating the so-called epileptogenic zone from the old-fashioned seizure onset zone, because the epileptogenic zone, by definition, includes not only the onset, but the early evolution of the seizure. So once we sort of get the concept of the epileptogenic zone, the next thing I jump into is that the most important part of SEG is actually what we do before the SEG, because by the time you have implanted, it's done deal sort of. So building the hypothesis is the most important thing in the SEG. And typically there is ways of looking into different aspects. Most of these tests in any level 4 epilepsy centers are done. But what is interesting, this came from Patrick Schuvel's very nice summary, is that you're looking into the interictal state, some of those tests. Some of the tests are trying to characterize the ictal state in the space domain. And then some of those are trying to quantify and look through different testing the lesion. And once you have this information, you have all the imaging, the anatomy, you have the clinical, the semiology, and then you have all the EEG. You put together all of this and then try to see, generate hypotheses and say, is there a likelihood of a unifocal epilepsy? And, if so, could it be through multiple hypotheses? And if those click that yes, there are multiple hypotheses, but there is a possibility that all of those hypotheses leading to unifocal epilepsy, that's when you say that this patient may be an ideal candidate for SEG. Sometimes you actually think that it could be an unifocal epilepsy and you do not have multiple hypotheses, that is, that there is a concordance between the anatomo-electroclinical. Some centers may say that, okay, we have what we need. We don't need to do stereo EEG unless there is an eloquent cortex overlapped. And if there's an eloquent cortex, then you need mapping. And that's when some centers still proceed forward with SEG. There are certain centers, they would say that, we may feel comfortable with subdural grids. So that brings us to the indication of SEG. And if you really look into it, there are three broad categories, so as to say. The first and the most important one is to really have multiple hypotheses regarding the epileptogenic zone localization. And that, in a sense, gives rise to sort of the SEG planning. If you do not have a good hypothesis, maybe it's not good to do SEG, including many centers often doesn't like to do SEG. Then obviously the second cohort of patients that often is good for SEG are MRI negative epilepsies. And the last one, the MRI positive epilepsies. And this is an important one, that where the MRI positive epilepsies, one may be trying to do SEG. These are some of those examples. For example, if there are bilateral lesions, but one of the hypotheses is that both the lesions may not be contributing to the seizure organization, and it could be one of the lesions. So that's an indication of doing SEG. Sometimes the electroclinical data does not correlate or overlap with imaging. Sometimes we see dual pathology. For example, we may see hippocampal sclerosis, but then this patient might be having temporal plus epilepsies. So these are some of those examples in MRI positive. The other one is that when the MRI, the lesion is very large and it's overlapping with eloquent cortex, we may want to do stereo EEG to map not only the functional mapping, but also the epileptogenic zone for resection or ablation or for device therapy. This is an example of all the panels of ways of SEG. There is sort of quote unquote a standardized format. That's number one. And number two, it's then further sort of individualized based on the patients. So I think both are important. One, to have some sort of template. And the most important thing, I've moved around the country, like when you all are talking about my CV, I moved around the country. I'll tell you there are a couple of things I learned. One is that it's always good to have template, so that you, within a center, to decrease the variability. The second one is important also, is to have sort of that you and the surgeon have an agreeable way of implanting the electrodes and naming them. And I think it's critical, to have those sort of a pipeline that is very much tuned with your institute, and I think some of the centers I have seen is that multiple things they're doing. Over a time, when you look back, it doesn't look good. So it's something that one learned from it. And then the other question is that how many electrodes we should be. So generally, rule of thumb. Now you go around, you talk to people. One is that the typical head box, the amplifiers, typically, if it is quantum, the head box, those typically go up to 128 channels. And if you have two head box, typically the recording and stimulation contact can go up to anywhere up to 200. But essentially, if you go around the country, people say, if you are putting 5 electrodes, and I have seen sometimes people do, you may not be needing SEG, or you're not doing the right way. And if you're doing 17 to 19, you are just, there is no real hypothesis and you're just exploring. So the ballpark estimate that everybody talks about is somewhere between 7 and 8 as a minimum, and maximum 15 to 16. Having said that, I've seen, we ourselves have done sometimes 17 and 18. We have at some point done phased. That is, we have first implanted SEG, and then we went ahead and added extra few more electrodes with certain hypotheses. So the next part is just looking into some of the EEG changes, and I just kept some broad view of it. So in your picture, what you're seeing is the A is basically the classic interictal spike, B is the runs of interictal spike, C is slow, sharp waves, D is actually seen often in focal cortical dysplasia. These are spikes, and then embedded on that is those fast activity or brush-like activity. These are often seen in Taylor 2 focal cortical dysplasia. And then the E is slow spike and wave type or slow waves and spikes embedded into it. And when you look into the ictal EEG changes, the two important things are, one, the ictal EEG changes depends on where it's generated, that is the anatomy, and then the underlying pathology. For example, low voltage fast activity is the most well-known studied. But having said that, there are other discharges or other ictal signatures that also can have actually class 1 outcome. For example, on your right-hand side, those EEG changes, it's highlighted there. So the first one is that the heralding spike followed by low voltage fast activity. The second one is just the fast activity, and the fast activity means it could be anywhere between beta less than 20 hertz. It can go up to that. Then the third one is this rhythmic sharp activity, often seen in FCD, followed by spiking activity, followed by low voltage fast activity. Then the next one is the repetitive fast spiking activity. Again, sometimes it's seen often in the FCDs. And then the last one are often called as the hypersynchronous onset. What it means, it's spike, 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 and then it may go into a low voltage fast activity, typically seen in hippocampal sclerosis. Traditional ways of thinking in the subdural was that low voltage fast activity are associated with good outcome and the others are not. But with the SEG, we do now know, for example, the hypersynchronous onset, the spike, 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 that's typically seen a lot into hippocampal sclerosis, can have a class 1 outcome. Okay, so this is a controversial topic nowadays. We are doing when we are doing this SEG. Is there a role of doing thalamic invasive EEG studies? This is highly controversial, and I just upfront I'm showing that recently at the Brain there was all these articles written about with the Nitin Tandon and Gottman's group questioning, is it really justified in clinical practice? On the other hand, Hooray, the Mayo Clinic, and others saying that yes, it is justified in clinical. So the debate really is that if you take away all the ethics, if you take away all the clinical, yes, it does, at times may give good clinical information. However, the debate often in thalamic SEG is, should it be done under IRB or should it be done under clinical, without the IRB? And one of the sharp sort of the debating features in this entire thing has been that the thalamic SEG, the SEG by definition has been done to sort of look for surgical potential, resection or ablation. The SEG has never been utilized to identify neuromodulation target because there was no neuromodulation, in clinical practice. So one of the points that we will see some of the senior faculty, some of the senior epileptologists um, debated that SCT is only for resection and ablation, and it is not for neuromodulation. Whereas in reality, as we are doing more and more invasive stereo EEG study, it does actually and likely as we move forward guide us in selection of just like anything else, just like it helps us to identify a target, therapeutic target, let's put that way. That is that SEG is used to identify therapeutic targets. Initially it used to be resection, then became ablation, and today and tomorrow it will be for neuromodulation. So that's the positive argument that SEG could be used, thalamic SEG could be used for neuromodulation target.
Great.
We
Dr.
were one of
Patti,
those.
we have
Yes.
maybe one more minute.
Okay, so I'm just
Thank you.
finishing it. Yeah, we have done this SEG studies, and I just wanted to tell one important thing is that if you are doing thalamic SEG, then the most important thing is you must do stimulation. If you're not doing stimulation, then I think its value goes away. And this is one example on a person where we were not sure what the target should be, and the patient got SEG for the ANT and the centromedian. And as you can see, when we stimulate the ANT, the seizures stopped or sort of gone. But when we stimulated the centromedian, there was no change. So it was an obvious sort of the result that this patient would benefit from ANT, and we actually implanted ANT on this patient. So in summary, SEG should be hypothesis driven, and the phase one is the most important one before identifying the target. It is interpreted as anatomo-electroclinical. And then if you are doing thalamic sampling, then you definitely should consider doing stimulation trial to identify the target. Okay, that's it. Thank you.
Thanks so much. That was so interesting. And I so wish we had more time. But I will have our next speaker pull slides up. So Dr. Nathan Crone is professor of neurology at Johns Hopkins School of Medicine, where he's the director of the Division of Epilepsy and Clinical Neurophysiology. He received his MD from Louisiana State University in Shreveport, did his neurology residency at the University of Chicago, and completed epilepsy and cognitive neurology fellowships at Johns Hopkins. So he will speak more about this functional mapping and stimulation. So thanks, Dr. Crone. And we will have time for questions later. So the thalamic stim is very interesting, and I'm sure we'll probably have some questions about that afterwards.
Okay, great. I want to thank everyone for inviting me and having me here. And I'll just try to get right into it here. I'm going to talk about intracranial functional mapping, and I have a couple of disclosures there, and we'll go right into the dominant method of functional mapping with intracranial from an intracranial perspective. I'll focus on that because we're really interested in spatial resolution at the level of a cortical resection, which I'll leave separate debate as to whether fMRI is really capable of giving you that kind of resolution. But we'll talk about intraoperative. I'll briefly talk about the fact that you can do cortical stimulation mapping intraoperatively and extraoperatively. In both cases, it's important to establish that you've got an effective stimulation and to establish a baseline of function. And I'll talk about that in a minute. But just to show the main advantage of the extraoperative mapping is that we can use the same electrodes that we're using for stimulation to also record spontaneous seizures. We can stimulate seizures. There's a lot that can be done extraoperatively that's outside of the kind of the time pressures that are intraoperative. Um, there's more time for functional mapping, and we can test multiple functions, and I'll talk about the value of that in a minute. So this is illustrating a couple of things. One is on the left, an intraoperative stimulation mapping procedure, and on the right, the extraoperative stimulation mapping procedure. So this is usually done by functional neurosurgeons. This is usually done by neurologists, but sometimes neurosurgeons do get involved here, and this is great. Um, this is also illustrating the difference between a positive motor response to stimulation and possibly, it's hard to tell in this picture, but possibly a negative motor response. In order to see these positive responses, very easy. You just apply stimulation to the motor cortex and observe. Um, it is important to start by stimulating an area that you're sure should have a motor response. Same thing goes for language. It's important to establish that you've got effective stimulation before you exonerate any areas because you don't see a response there. Um, and and likewise, well, I'll talk about it with language. It's very important to establish a baseline that the patient can perform the language task that you are asking them to do, and that you're going to observe interference with that language task. The advantage of stimulation mapping is that it simulates a lesion in the brain, in particular for language. Language, we don't get positive responses like we do with in motor cortex, um, and also in sensory cortex. We're usually getting just negative responses. We don't cause people to speak usually. We interfere with their ability to speak or with their ability to understand speech. Um, so this is just illustrating this patient holding out his arms, and we're asking him to wiggle his fingers, and we're observing the effect of stimulation. We've got a nurse over here that's going to deliver the stimulus. This is a very old picture, but this is also showing us. We've got tokens on the table for a token test. So that's a test in which we're asking the patient. This is a language task. It's testing comprehension, and we're asking the patient to move, pick up, or touch each of these tokens, and we can give three-step commands to see if the patient can follow those three-step commands. We can simplify it if they're not able to do three-step commands at baseline. So language, testing language is a bit more complex than testing motor function. Usually it requires higher stimulation intensities, and the choice of task is very important. So you can see a list of different tasks that people have used for testing language. It's important not to just rely on one task if possible. In the operating room, time is very limited, and you may resort to some very simple task that the patient can reliably perform in this kind of stressful situation. So it might be simply counting or reciting the alphabet, but understand that those are very highly automated tasks that don't really require very much linguistic processing. And so when we do have more time and we can test things more thoroughly, then we're usually using a battery of language tasks. And for example, at Hopkins, we use this battery of language tasks. First, the very simple thing, we're just asking the patient to talk about some topic, and we're seeing if we can induce speech arrest. It's very, I think, very important to test comprehension aside from just production of speech. It's also important to test production of speech. And the most common tasks for that are visual naming, showing a picture of an object, and auditory naming, describing an object verbally, and then the patient has to produce the word. It's good. It's important for the language task to have a very discrete and quick response, so that you don't have to stimulate for a long time. You want to time the stimulation for no more than about 5 seconds if possible. And the reason for that is the longer you stimulate, the more likely you're going to run into a very common complication of stimulation mapping, which I'll get into in just a minute. So the stimulation parameters, the typical stimulation parameters are listed here. I won't go into detail here, but this is the most common stimulation parameters that are used. And usually the train duration is about 2 to 10 seconds. It's important to start low and go slow, and that is to avoid after discharges and avoid triggering seizures. If a patient has a seizure in the middle of the stimulation mapping, that's the end of the session usually, and the patient has to recover from that seizure before you can do more mapping. The amount of stimulation that we give is dictated by the charge density, which is dictated by the geometry of the electrodes, how big the electrodes are. The smaller the electrode, the higher the charge density is usually. Okay, so this is the complication that we want to try to avoid with stimulation mapping. It's going to happen no matter what, unless you heavily pre-medicate the patient. We often will wait until we've recorded spontaneous seizures, and this is one of the drawbacks is we may have to wait until the patient has had spontaneous seizures or stimulated seizures if we've waited too long for spontaneous seizures. And then we'd like to medicate the patient. It's going to be easier to do the stimulation mapping because the threshold for interfering with language is often higher than the threshold for triggering a seizure. And this is just showing the kinds of waveforms that can be triggered. And these are all after discharges. They're all different forms of after discharges. And these can evolve into a seizure. You'll see them spread to other electrodes. You'll see the patient start to have symptoms. And depending upon the stimulation threshold at which the amount of stimulation you gave, the intensity, and whether they're on medications or not, it may or may not really mean that this is the seizure onset zone or the epileptogenic zone. What we can often do to interrupt the after discharge is give a brief pulse of stimulation, and believe it or not, that can just stop the after discharge, can stop the patient from having a seizure. This observation was really the genesis of the idea of using the responsive neurostimulator, and it was developed based upon these observations. I'll just also say that another really interesting trick is you can have the patient perform a mental arithmetic task to interrupt the after discharges. So just engaging the brain in another task can interfere with the evolution of the after discharge into a seizure. And this is something we do routinely at Hopkins. We'll give a brief pulse stimulation. If that doesn't work, then we ask the patient to perform a math problem. The more challenging, the better, but not too challenging, or they won't try. The other thing to be aware of is that you can get intrastimulus remote discharges. So this speaks to the localizing value of the stimulation. We assume that the stimulation is the effect is very local, but there are instances where we can see discharges in distant areas. This is showing stimulation in the basal temporal language area. This is a very old picture without a reconstruction showing the anatomy very well, but this is where we were seeing language responses stimulating here. We could see intrastimulus discharges in this area. So making you wonder, is the effect just limited to here? There is a basal temporal language area, and that is very important to know about. But in this case, we may have been getting some false localization here. So some other limitations of cortical stimulation mapping is that it can be painful in some sites, and it can stimulate trigeminal afferents and blood vessels. It also gives us an all or none response usually. So that can be a little bit challenging to interpret. And it can be very time consuming if you use a language battery, like I mentioned. Another thing is that in children in particular, it's quite common for it to be difficult to interfere with language, with stimulation. And in children, the stimulation thresholds can be larger, and it can be difficult, if not impossible, to localize language in children under 10 years of age. So all of these limitations were the motivation for developing passive mapping, and I'll just try to briefly go through that. Passive mapping is based upon these kinds of responses that we see, these broadband high gamma responses that we see with functional activation when we are recording from the cortical surface or in the depth of the cortex. I will take a moment here to say that everything that I've talked about so far, you're seeing a lot of illustrations from subdural electrodes. That's because these techniques were largely developed in that era, but they do apply with stereo EEG as well. So there is an FDA approved or FDA cleared turnkey solution for doing passive mapping based upon the high gamma responses that I just showed. And this is the device. It can be used extraoperatively, like it's illustrated here. It can be used intraoperatively. It is something that can be done at the bedside. You can get immediate results, and I'll illustrate that in a minute. But it's based upon a block design of spectral analysis where you've got a long rest interval of several seconds and then an active interval where the patient has to engage in a task. And this is a video illustrating the use of the technique. So the patient is being prompted to solve a Rubik's Cube. So they're using their fingers, and then we're seeing progressive activation of, here's the Rubik's Cube map. And so the map is kind of evolving as data is being accumulated, and this kind of rest versus activation is being used. So now the patient's listening to a story in Japanese, and we'll see activation in, unfortunately, the electrodes were not really in an ideal location to see the activation here. And you'll also notice some interesting activations in other places. And so this technique does require some knowledge of functional anatomy in order to interpret the responses. That can be both fun and a little bit challenging at times.
Great,
So you need to be
yeah. Sorry, let's just finish up in just a few minutes.
Yep. Okay, we'll do. So this is just illustrating a different way of looking at the same thing. So this is being able to resolve the timing of the activation. And this is just showing different kinds of maps for different language tasks. Here's picture naming. Here's auditory word repetition. And so you'll see different patterns in the spatial temporal evolution of the brain activation. This is just showing that this technique can also be used with stereo EEG. This is software that we developed at Hopkins. Unfortunately, there really isn't, other than the system that I mentioned, the CortiQ system that I mentioned, there isn't really other commercial packages to perform this. So this is still very much kind of in the research realm, other than the package that I showed you. I'll just go ahead and skip forward and to the conclusion here and say that electrocortical stimulation mapping is still the gold standard for language localization. It's because it simulates the effects of resection, but it does have a number of practical limitations that I went through. The passive intracranial EEG mapping does not simulate a resection, but it can complement electrocortical stimulation mapping, and it can be done more efficiently, more quickly, and with less stress, and no risk of seizures. It is important to be aware that there are some artifacts that can interfere with the mapping, like a lot of interictal discharges can interfere with the mapping. if there was very frequent spiking. And I would say the clinical validation is still ongoing, but there is already an FDA-approved solution for doing that.
Fantastic.
And that's all. Thank you.
Thanks so much. All right. And so we'll transition now to our last speaker, Dr. Chengyuan Wu, Professor of Neurosurgery at Thomas Jefferson University and Division Chief of Epilepsy and Neuromodulation Neurosurgery. He's also the Fellowship Director for Stereotactic Functional Neurosurgery Fellowship, FYI to the residents out there. Did his medical training at Tufts University, residency at Thomas Jefferson, and fellowship there. And he'll be covering kind of the nuts and bolts of SEEG procedure.
All right, thanks, Bornali. Hopefully you hear me okay. So I'm gonna try to, stay on time here, and this is gonna be a little bit more of a nuts and bolts talk about, from a surgical standpoint, how we think about the actual invasive implant. Here are my disclosures, none of which are particularly relevant to this talk. So, Dr. Pati talked nicely about the different options, subdural versus SEEG. Dr. Crone showed some examples, and I think we all know what we're talking about. Doing a craniotomy, placing grids over a general location versus stereotactically placing electrodes effectively percutaneously. And these, I would not say is necessarily one better than the other. It's time and place, and when one is needed versus another. And so to think of it a little bit conceptually, right, we think about how the gray matter is distributed in the brain, and just roughly about a third of the gray matter is on the cortical, the crest of the gyri, and about 2/3 of the gray matter is in the depths of the sulci. So we are inherently looking at different parts of that gray matter distribution, usually with the cortex and that surface with a grid, and more at the depths with a SEEG, or if you put an SEEG this way, you can get a little bit more of the crest of the gyrus as well as the depths of the sulci. So out of curiosity, we wanted to quantify this at least visually, and you can see how on the top you have an expanded, inflated brain on the right-hand side in both scenarios, and the grid generally gives a more contiguous representation of the crest of the gyri as you would expect, and to a relatively localized region as you inflate that out, versus you can see why SEEG fits the whole idea of having a network-based theory of epilepsy more, because you are more densely sampling these nodes in a more distributed network. And so to Dr. Pati's point, certainly having a very clear hypothesis before you do SEEG will help you determine which nodes you need to sample. Otherwise, it's just not the right technology for that approach. On top of that, from a surgical standpoint, we always look risk and benefit. We just talked about a little bit of the benefit. In general, there's a little bit of a busy slide, but SEEG is safer. There are lower risks inherently involved. And so the willingness to do this sort of procedure certainly has a lower barrier than with doing craniotomy for grids and or strips, which was more common practice, at least when I was in training and so forth. But what it all boils down to, I stole this slide from Dr. Gonzalez-Martinez. It's a nice summary, is that ultimately it's kind of time and place. A lot of times SEEG is right, especially if you're looking at deep locations. That includes a lot of cortical dysplasias, which may sit at the depths of the sulci, or if you're looking at epileptogenic network and trying to map that entirely, versus trying to map things on the surface, especially when it comes to eloquent cortex. And for us in our practice, this primarily applies to receptive speech areas in the posterior temporal lobe. There has been good literature about how to do this with SEEG. It's just certainly from a surgical intervention and interpretation standpoint, a little bit easier to understand with the grid. And that grid picture I showed you in the beginning was not from a while ago, that was from last year. So there are times and places that we still find a need to do grids over SEEG. So going more into the SEEG technique, because grids is fairly straightforward. You do craniotomy, you place the grid over the location that you want to interrogate, versus SEEG takes a little bit more. And I think the main thing here that we have to appreciate is that, again, as a stereotactic procedure, effectively percutaneous procedure, we have to be very sure of what we need to avoid as well. This is the way that we do things here at Jefferson. We get a Dyna CT scan, which is a catheter angiogram that is converted into a CT-like reconstruction. And you can see on the right-hand side, the video that played is a merge of a contrast-enhanced MRI. along with an angiogram. And what you have to understand and what you have to communicate with your neurovascular colleagues who do these angiograms for us is, what different injections may be needed. You don't need a 5-vessel angiogram every time you do this. Often you might only need 2, sometimes 3 vessels, but understanding the distribution of your vasculature to understand what you need. A typical bitemporal implant may need ICA injections as well as a vert injection, because again, that vert injection, as you see in blue, will encompass that basal temporal and posterior temporal lobe. That is if you are going to, employ angiography in addition to your MRI. Now, I advise doing something in addition to just a typical contrast enhanced MRI. It's not necessarily that you do an angiogram. There's many other methods. There's double contrast methods and other MRI approaches that have been shown to have better visualization of vessels than just a typical gadolinium image alone. But the reason I say that is this is an example that we saw, is that, if you look at this image, this is just a T1 GAD. There looks to be on the left-hand side of the brain, the right-hand side of the screen, a clear area in the vasculature where you may enter in the superior frontal gyrus. This would be for something like an insular electrode, which I'll show you those sort of tractions later. But if you pan between the angiogram and the MRI, there's this blood vessel that is otherwise invisible on the MRI that, if you didn't have some additional vascular imaging, would have been missed and may have led to a hemorrhage. So we continue to do this. It might be overkill in some scenarios. It gives us better confidence that we are certainly avoiding blood vessels that, yes, they may typically be within the depths of sulci, but you do have cortical vessels that run across gyri, and we don't want to miss these either. Get out my video. Okay, so let's talk about some typical trajectories. There's a dozen different ways to skin this cat. And, we try here to maintain some integrity for the old Taloac system. I think having relatively orthogonal trajectories is beneficial for a few reasons. A, it makes the SEEG easier to interpret for our epileptology colleagues. If we start taking weird, funky angles, you get away from that 3-dimensional grid, and it becomes a little bit harder to interpret exactly what we are recording from. On top of that, the more that you have just straight orthogonal angles, the less you have to worry about collisions of electrodes, whether intracranial or extracranially, so it makes our job easier in terms of planning. And then finally, in general, if you take these sort of trajectories, you have a more perpendicular or normal angle to the bone surface, and it's less likely to skive. So typical amygdala trajectory will come in through the middle temporal gyrus, go straight across into the amygdala, as you show in the top left. Hippocampal, we usually do, if we want to look at the entire hippocampus, hippocampal head, body, tail, marching back in approximately 10 to 15 millimeter intervals, again, as orthogonal as possible. And then it's also important to record not only from the mesial structures, but neocortex. You get some neocortex with these electrodes already, but it's fairly limited. So here's an example of a basal temporal electrode coming a little more posteriorly in that basal temporal lobe where you might have neocortical involvement. And you can see by placing it lower, you get the base of the sulci, of multiple sulci on that basal temporal lobe. Similarly, I don't have an example of it, but I think also important to sample in the neocortex is temporal pole, which would simply be similar to this amygdala electrode, but just anterior and through the middle temporal gyrus. Now, other temporal limbic network trajectories that are fairly typical, then, I think this goes to sort of the template approach that Dr. Pati was talking about. This is sort of our template that we tend to adhere to and say, do we want to add cingulate? Do you want to add orbitofrontal to our typical temporal implant? Orbitofrontal, I try to come in the inferior frontal sulcus, so it stays as low as possible. If you do that, you can see that, again, you get a lot of this basal orbitofrontal, as opposed to if you come high from the middle frontal gyrus, you miss a lot of this gray matter on the basal frontal lobe, which is the whole intent of interrogating orbitofrontal. And in some of the work that we've done, we've seen that posterior orbitofrontal cortex may be more involved with limbic networks rather than anterior orbitofrontal cortex. Cingulate tends to be relatively straightforward in terms of planning and orthogonal trajectories to cingulate gyrus. The question really becomes where in the cingulate, because the cingulate is enormous and it really speaks to what network you're really trying to involve. Posterior cingulate, maybe more basal temporal connected, anterior cingulate, more mesial temporal. There's some good neurophysiology as well as imaging studies that show general connectivity with areas of the cingulate. But in all honesty, it's hard to have a good quote unquote cingulate coverage because I think our understanding of what connects to what within the cingulate is still somewhat limited. Now, the last thing I'll talk about in terms of technique is insular, because insular was kind of the hot topic when SEEG became more popular in North America. And there's multiple ways to do this, kind of going from old to new, from left to right. The French typically do this transopercular approach so that they can get these anatomical electrophysiological correlates with the operculum as well as the insula, which is nice. But the downside to this approach is that you only get one or two contacts in the insula itself, and the rest are kind of in white matter. We started with this approach on the right-hand side where we tried to recreate the tetrahedron of the insula with 4 electrodes you can see here. But that also was a little bit challenging in terms of how to plan and what we can do with that information. So this is our approach now, where we effectively go down each of the gyri and get very good coverage of the insula. Now, this is not something we would do in every patient. More typical for temporal plus type concerns, we would do effectively just maybe the anterior 2 electrodes and maybe this posterior one, because this posterior one maybe have more neocortical basal connections, and this anterior 2 may have more mesial or anterior temporal connections. But rarely will we do all this. This is just a graphical representation. Now, the reason why this approach is nice is that, well, first of all, how do we do that? As I mentioned, this trajectory comes very close to the midline. So again, having good vascular imaging, like I showed, is important. We try to go down each of those gyri, the short gyri anteriorly, the long gyri posteriorly, depending on what we're doing. And you end up hugging this gray matter out laterally, again, coming through the superior frontal gyrus, being careful to avoid any blood vessels. The nice thing about doing this is that you get very dense insular coverage, so that if you have either insular early spread or insular onset, this is probably the most common scenario in which we do RF ablation of a seizure onset zone or a zone of early spread. Because it's technically challenging to reach the insula surgically, this is a nice way to handle it. And the French data has shown that this can be very beneficial, certainly somewhat to a therapeutic standpoint, but for short term, more so from a diagnostic standpoint, and saying that if you have seizure freedom for at least 2 months and then subsequently do a resection, you have a very high positive predictive value of a resection in the order of 92%. The other nice thing is that if you do electrodes in this manner and not straight through on an orthogonal, so this is where I'll break my orthogonal rule, is that these insular electrodes come from the top and allow us to be a guide for our resection. We will leave these in and then do a terional or temporal-like craniotomy to do a resection of the insula. This is anterior to the left, as you can see here, inferior is up. But these are the insular electrodes that we've put that serve as fence posts to our insular resection, knowing that if we see the contacts where we recorded onset, then we certainly resected what we intended to resect. It also provides some degree of safety in terms of making sure that you don't resect medial to these electrodes and get into the internal capsule or anything that would be of concern. So just to wrap up, in terms of other targets, Dr. Pati talked about a little bit about thalamic SEEG, so I thought it'd be worthwhile to look at that. I think it relies heavily on good visualization, good preoperative MRI of these targets. Anterior nucleus is something that we would do in a limbic type interrogation on occasion. That target is typically at the top of the mammillothalamic tract. If you can see on the top right, it would be kind of this Y structure that you would target. Now, you certainly cannot do SEEG the same way you would do DBS. Well, if you do DBS in a transventricular trajectory, which most do for anterior nucleus, because there's no cannula with SEEG, it's impossible to do a transventricular trajectory. So you have to come kind of lower down through the operculum and get into the anterior nucleus that way. For central median and pulvinar, you usually use an MP2 RAGE. that is median edge weighted as a post-process image, then this was a nice publication by Warren et al. That shows this sort of imaging. This is the idealized form. On the left-hand side is what we actually get. And you can sort of see this, iso to hypo intensity of the centromedian, as well as the hypo intensity of the pulvinar. That helps guide you in terms of where you may put those electrodes. And again, those would come from a more lateral trajectory that get pushed deeper into the thalamus. So to summarize, I think if we look at the different modalities of monitoring, SEEG is predominantly beneficial in terms of sampling sulcal gray matter as opposed to the gyral crests. We like, and we are very biased to use a DynaCT catheter angiogram reconstructed scan. But again, if you don't do this, at least some additional form of vascular imaging to help minimize risk of hemorrhage. Implantation along the insular gyri helps maximize sampling and help facilitate the RF ablation as well as surgical resection. And then when it comes to implanting the thalamus, I think it really comes down to visualizing those nuclei as best as possible. I didn't mention it specifically, but some version of a white matter null or F-gator for anterior nucleus and an MP2 RAGE type sequence for centromedian or pulvinar. Thank you.
Fantastic. Thanks so much. Questions? We have just a few minutes left for questions. I don't see any in the chat. I hope I'm seeing the right thing, or Dr. Benheim. I'll just ask one then. So going back to the thalamic electrodes, because I think that is kind of a real controversial, new, could be really important, we just don't know the value yet thing going on. I was just wondering if any of the speakers could speak a little more about, I guess, how many thalamic electrodes are going in on SEEG montages, like one per nucleus. I've heard people implanting mediodorsal. Is there a reason to do that? And I know this question we can't answer completely in 2 seconds, but just, well, a seizure is necessarily going to go to the thalamus probably. So it is 1 millisecond enough, 5 seconds later it goes to thalamus. So should we just do a thalamic implant or what? So please answer that in 3 minutes.
Go ahead first. Chengy, you want to?
No, you're the guru on this. I'll defer to you.
No, I think essentially, I think the way people have looked into it, that they have implanted ANT if you're suspecting limbic, if you're thinking posterior quadrant, pulvinar, and then if you're thinking about sensory motor cortex, then or generalized sort of pseudo-generalized features are there, or GTCs, people have done centromedian. I'll tell you, one important thing is that a lot of people don't like when anyone is doing multiple thalamic subnuclei. And that's because people are worried about, the volume of tissue that you're poking within that small area is actually significant. I think somebody is writing a paper as we're talking and trying to highlight that as a criticism. Somebody has done some calculation and showing that if you're doing 3 electrodes on one side, that's a lot, or 4 electrodes on one side. I think it's a lot. So that's the first important thing. And how quickly the seizure spread. I think the Mass General people looked into it. There is no hidden rule. All we know is that if it propagates very early, then it might be involved in the network versus if it is late. And they used at least looked into 6 seconds, and they looked at whether it spreads or not. But the association with outcome has not been done yet. So we don't know. That's the right answer.
Gotcha. Great. Really interesting. Though I will add that, from the movement disorders perspective, and, we used to, not me personally, I've never done a full bend gun, but, there used to be like 5 electrodes going into thalamus all the time. And I'm not saying that there wasn't a lesion effect, but certainly people turn out okay, I guess, my understanding. So very cool. Well, Dr. Benheim, did you want to make some announcements about our next session?
Yeah, well, thanks everyone. This was really a fantastic session. I do want to announce our next session in this series, which is our epilepsy series, will be around surgical treatment options, and we'll specifically delve into a lot more of these concepts around neuromodulation, talk even a little bit more about SEG and how predictive that is, and then really dive into detail about the various targets and also hear from some neurologists about their perspectives and how they program these targets and how they think about planning for these procedures as well. So nice multidisciplinary collaboration. I really, really want to thank you all again for this fantastic session. Truly excellent speakers and moderator. And I want to thank the audience for joining us this evening. And we hope to see you at the end of the month in Cleveland at our ASSFN biennial meeting. Thanks, everyone.